Srinivas is from Coimbatore with Trinity Eye Foundation.
Trinity Eye Hospital.
Sorry. Dr. Subhash Prasad, I always tell he was the senior resident to my senior residents, an exceptionally good speaker, and he's from Patna. Sir, please go ahead with your talk.
Thank you,
on premium monofocals.
Thank you, Dr. Allen, for accommodating me in this series, in this IC of yours. So I would be talking on premium monofocals, technology advantages and disadvantages. We all know that phaco with the foldable eye is the procedure of choice for any cataract surgery nowadays. And with advancements in technology, there has been a lot of changes in the intraocular lenses also for in last few decades. But the profile of the patient keeps changing, and this is putting a lot of pressure on not only on industries but on ophthalmologists to perform and to give a better and better result. And there has been a rapid shift to digital platforms for last few years that has created actually a rapid increase in far through near vision demands. So as a clinician, our goal is to have a happy patient at the end. So this is also moving very fast.
Thank you.
So what is ideal IOL should have been? It should be able to give vision for all ranges, should be able to give good quality of vision in low or bright light conditions, and there should not be any negligible night vision problem or no problem. So traditionally also before the advent of the trifocal or EDOF lenses, we used to use some kind of offset in the IOL power calculation, which is called monovision, to just make some of the patients who actually wanted some near vision to make them happy. But the revolution was with the introduction of the bifocal lenses or trifocal lenses or EDOF lenses. But these lenses are not without compromises, particularly the night vision problems, and the cost is a very limiting factor. So if you are really worried about the compromises like the night vision problems or low contrast, or if you want just some better functional vision at more distances, then premium monofocals, which is a new concept, can be a very good option. And these are basically monofocals without any concentric rings, or so they don't split the light energy into different places. Rather, this technology uses a different kind of like slight change in the central power, or utilizes the spherical aberration of the lens to give superb distant vision. Not only superb distant vision, but also intermediate vision and some amount of near vision also. And if you implant these lenses bilaterally, then these lenses perform even better than the simple monofocal lenses, and patient can utilize a lot of intermediate work with these lenses. And if you do some adjustment in the other eye, like you do monofocal kind of adjustment with slight offset to the power, the patients can have even still better. So these are the three lenses which are available in the market nowadays. Technics enhanced intraocular lenses, which came first. Then came the Renner, and the Vibinex from the Hoya was launched few months back. And with these lenses, some of the patient really can have some improvement in the intermediate vision. So what is Technics enhanced lenses? This is basically using the same platform of Technics 1 single piece lenses, and you cannot make out any difference. How does it work? There is small continuous increase in power in the central 1 millimeter diameter zone of the aspheric anterior surface, which actually gives around 0.5 diopter of change in the power, and which enables us to have an enhanced intermediate vision with better image contrast as opposed to the trifocal or EDOF lenses, and it is flexible also. The monocular defocus curve shows a better defocus results between 1 to 1.5 diopter, and even the binocular defocus performs better, and it achieves a smoother profile along the entire curve, especially within the intermediate defocus range. It provides higher independence to the spectacle as far as intermediate vision is concerned if we implant the lenses bilaterally. And the night vision problem or the contrast is even same as the monofocal lenses. The another lens which is available in the market is the Vibinex Impress, which is on the platform of Vibinex, It comes as a preloaded. The other one was is not preloaded yet now, but it's going to be launched as a preloaded version. The toric form is in the preloaded form. This lens is available in the preloaded form. Here there is slight alteration in the central 2 millimeter, which actually enhances the intermediate vision by one line. Here also you can see the defocus curve. It enables us to have a better intermediate vision by 0.5 diopter. The lens which I find much more useful than these two lenses, I have no financial interest to any of these lenses. Recently I started using this Raven EMB, which is hydrophilic lenses. It was developed in collaboration with the Professor Graham Barrett. It is actually, the name suggests, Rainer EMB means enhanced monovision lenses. It can deliver up to 1.5 diopter of high quality vision. It utilizes a unique positive spherical aberration designed to extend the intermediate vision and some amount of the near. At the same time, since it is a non-defective IOL, so it's just like monofocal IOLs, so there is no night vision problem, and it comes in beautiful preloaded pack. How does the EMB lenses work? The anterior surface of the aspheric, the lens is aspheric, but the central region induces controlled positive spherical aberration of say around 0.15 micron, which extended the depth of vision, and this zone is blended with the aspheric zone, so there is minimal loss of visual acuity or contrast sensitivity, and being non-reflective, it doesn't have any night vision problem. So this, you can see that how the spherical aberration can shift the focus for quite some distance. This is the defocus curve of the Rainer EMB lens as opposed to any monofocal lens. If you offset it by little bit, say around 0.5 diopter, you can manage the patient to have to give nearly 1.75 diopter of extra benefit in these lenses. And if you give 1 diopter of monofocal of monovision in the other eye, the patient can have very good near vision also. This is the chart just to show that if you adjust the lens, you offset the lens by 0.5 diopter, you can cover to some extent even the near vision also in these patients. But all these lenses are not only without advantages. There are some limitations. Advantages being that with so low cost, you can give some amount of intermediate vision and even some amount of near vision without any night vision problem. But these lenses do have limitations, and it is said that in optics there is no free lunch, because the photons of light which is going inside the light is constant. So if you are adding somewhere here, you are actually decreasing some amount of distance vision also. So that is one flip side of these lenses, that you can, but practically it doesn't affect much, since already patient of cataract, they have low vision. So once they get this amount of good vision, they are very happy. And the other limitation is that just 0.5 diopter of increased depth of focus is with the other two hydrophobic lenses, but with the Rainer it is even more than that. So you can have additional 1 or 2 line of intermediate vision, that is around 60 centimeters of the distance you can have one that. One has to remember that this is not an extended depth of focus lenses like Symphony or VVT, so the patient will not have that much of good vision. Our experience, we have implanted nearly 25 eye hands, EMB is 51, and what I feel that the EMB lenses are doing much better than the other two lenses, and the patient's happiness is much more with that. Only disadvantage that this is hydrophilic lens, but in last 9 months I have not come across to any PCO also. So patient satisfaction is best with the this is just a small video clip just to show that this lens is so good to implant. This is toric, it comes in toric form also, just 30 seconds. Alan. So this goes with the 2.2 millimeter without any wound stretching, and this stays in the place in the toric also, it gives very good results. So just to summarize, it's exciting new concept to address the new intermediate vision and some amount of near vision with the monovision concept. And this is cheaper version, you can say this is cheaper version of the ADOF IOLs, giving good quality of vision without any night vision problem. So thank you very much.
Thank you. Can it be called as a true ADOF IOLs?
Actually, FDA doesn't approve these lenses as ADOF. Yeah. There are certain criteria which has to be fulfilled. So this.
But they provide the benefits of like that of an ADOF.
Yeah. Yeah, yeah. That, just my personal experience, I want to share that I have implanted so many VVD IOLs, and when I compare these two, at the cost of 1/3 or less than that, the patient much more happier with this Rayner lens. Yes.
No, I think now even the eye hands now they are commercializing as advanced monofocal plus. They are not pushing as EDOF. So
Yeah,
they
yeah.
also know.
So do we do? So do we counsel our patients for these IOLs or EDOF ones? Because this is a very important. I mean, when you are going to a premium set of IOLs,
No,
true EDOFs are little too costly, and these smarter EDOFs are less costly. But what do you explain to the patients?
see, with the EDOP, I explained that you will have a very good intermediate vision, but you will require some amount of the near vision. But here you won't have any near vision, particularly those IHANs and other.
But with no financial interest.
Yeah.
Is there any difference between that Vivity EDOF and this iHands Smart EDOF?
No, these are not EDOP actually. The IHANs is not EDOP. DVT is designed to give much better intermediate vision, and it gives some amount of near vision also. I have seen patients who require just 0.75 diopter of additions, 0.5 even bilaterally. Some of the patients did not require any near correction. So
So you mean to say that we should keep these patients in, I would say, extended monovision. That is all.
Yeah.
I mean, switch over to that, not EDOFs.
just slide one line of improvement with the near vision, nothing more than that. But Rayner performs better.
Sir, in
Just clarify on this, what you asked. Technically speaking, sorry. Yeah, technically speaking, all these are extended depth of focus lenses. All these lenses, whatever sir was trying to explain, central increase in power, it's not just the power, it's the asphericity that has changed. We are playing around on that. I'll have a slide on that. I'll be talking about it. Number two, but FDA considers EDOF as above 1.5 diopters. If it can give 1.5 diopters at least of addition, only then FDA considers it. So what you named as true EDOF, there's nothing called true and false EDOFs, nothing called like that. But these are also EDOF lenses giving less than 1.5. That's what sir was telling, intermediate is good, near is not good. There is a method to play around for that. That is the blended vision correction, where 1.25 to 1.25 is given by Rayner EMV lenses, 1.25 to 1.5, it goes till there. So in the other eye, that is in the non-dominant eye, give a slight overcorrection of 0.75 to 1.
Yeah.
I have nearly 200 patients with this, and almost all of them, both eyes, 6.6, 6.9 with at least N8 near. Intermediate is N6. 200 of these lenses, and I'll be very happy to say 125 of these lenses are Indian lenses. Okay, Indian lenses are also available in a very cheap category. I'll be coming to that. I don't have a slide I have a slide, I'll be talking about it at that point of time. Okay, now with this you can balance, but how to decide what lens for what person, that's a different talk. So technically speaking, these are also EDOF, but it's not classified under EDOF in the FDA category for insurance purposes only. That's all.
Sir, in continuation of what Dr. Ilan was saying, your presentation, your wonderful presentation on monofocal and to some extent on EDOF. In our day-to-day practice, no matter how much we explain, talk in the scientific field that premium IOLs, you should look at the lifestyle. But at the end of the day, every patient, whether it's a computer-going, office-going person or a common man, at the end of the day, everybody wants to say, Dr. Sahab, nazdeek mein wo saaf nahi dikh raha hai. And we are coming out with so many lenses of premium monofocals and premium EDOF lenses. But at the end of the day, patient wants to see near. Just like Dr. Ellen said right now, what do you do in your practice to ensure that even though you are giving a EDOF lens, do you do some addition or something to this EDOF lenses that patient somewhere at least gets N8 or N6 partial?
Yeah, some of the patients require, most of the patients with EDOP require some amount of near correction.
How much addition do you do in your biometric calculation to make sure that the patient, even though compromises 6/6 may become 6/9 partial?
No, in biometric or after surgery, biometry, you can just play with some amount of overcorrection in the other eye,
How much do you play with?
0.5 to 0.75 maximum.
That's what I want.
Okay, sir. Thanks a lot.
Thank you. Sorry,
may-
I have to go to some other hall.
Yeah, thank you for the